Jagdish, we can continue the theme because they have been introduced to Dr. Paul Whelton, who is going to then today and tomorrow, and he's going to give his remarks. Paul, the screen is yours.
Thank you, Venkata. Just next slides. Okay, so thank you, Venkata. It's a wonderful privilege and pleasure to be with you and with all of our colleagues in India. Send you greetings and good evening from New Orleans. So I'm going to talk about our challenges going forward, and I have no conflicts of interest. So, let's start with the obvious. You know this as well as I know it. There is a huge burden of illness due to high blood pressure, and the epicenter of that is in Asia, and the two leading countries that have the biggest challenge or burden of illness are India and China. And most of that is manifested as ischemic coronary heart disease or stroke, either hemorrhagic or ischemic stroke, progressively moving towards ischemic stroke. And there's a continuous relationship between level of blood pressure and adverse outcomes. It goes all the way from really low levels of systolic, 90 millimeters or so, all the way up to the highest levels we can measure, over 180. And of course, we look at this and say, if we had a perfect cure, if we could just flip the switch, which we can't, we can improve, but we can't cure generally. At what level of blood pressure would we need to initiate drug treatment to be helpful? And we can generally estimate that if you're looking below the curve here, if you could successfully manage everybody that was above 150, that would really be helpful. It'd get you close to 40 to 45% of the blood pressure related events. If you went a little lower to initiate the treatment, 140 and above, you generally get at about 2/3 to maybe 70%. There'd still be a lot of blood pressure events that are occurring at lower levels of blood pressure. So job one for a country that hasn't really got all of those with the highest pressures controlled is to do that. But in countries like the US, where we've done a reasonable job at those higher pressures, we've started to move down to initiate or add drug therapy at slightly lower levels. Now, when we look worldwide, my colleagues and I at Tulane have done a number of estimates using the available population-based survey data where there is proper national or regional sampling. And I'm going to show you here are the data for 2010. We will update this, but it takes a while to get all the data in place to update it. And this is awareness, treatment, and control. And I've split it into high-income countries and low and middle-income countries. And either way, it's not good. High-income countries, even to control to less than 140 over 90, a substandard level now for any major guideline. No major guideline is saying you should be satisfied to only get below 140 over 90. But even at this rather low standard, less than 30% in high-income countries, and in middle and low-income countries, less than 8%, 1 in 13. Now, India would fit somewhere in the middle income countries. And if we look at India, to the best of my knowledge, there's not a true national probability survey, but there are a number of regional surveys that are well done and they've been pooled. And so we can get national estimates. And I'm going to focus over here on national estimates for control. And it's quite different in urban areas and in rural areas, but whether you're looking at urban areas or rural areas, again, even to a rather low standard, less than 140 over 90, we can all look at this and say, we're not doing well. We need to do much better in the future. So that's the starting point. None of us are doing as well as we should be doing, and we have a lot of work to be done. Now, Dr. Wright and Dr. Cushman and I have been on many guidelines over the years, and Dr. Wright and I were on the ACCHA US guideline for 2017. Most recently, I participated in a guideline that was produced for the World Health Organization, and this was specifically targeted to middle and low income countries. And I just want to show you here what we recommended based on a review of the available data for thresholds for initiating antihypertensive drug therapy. Now, this is in the context of individuals who are recommended already to get lifestyle modification. So we said it's a no-brainer that you would initiate drug therapy for anyone who has a correctly measured average systolic pressure of 140 or above, or diastolic of 90 and above, and that's a very strong recommendation. We went a step further and said for those in the 130 to 139 category of systolic blood pressure, if they have existing cardiovascular disease, again, there is strong evidence that you should be introducing drug therapy in addition to lifestyle modification. And we said even in those 130 to 139 who haven't already had a cardiovascular event, but who are at high risk for cardiovascular disease or have diabetes or chronic kidney disease, we would also recommend introducing drug therapy. Conditional recommendation rather than a strong recommendation. And we recommended the same sorts of classes of therapy, of drug therapy that are recommended in all the other major guidelines. So 3 classes or 4 classes, depending on whether you're lumping ACEs and ARBs together or you're splitting them. But we recommended thiazide and thiazide-like agents. We recommended ACE or ARB, and we recommended long-acting dihydropyridine CCBs. And that was a strong recommendation, high certainty evidence. We suggested initial combination therapy using the agents from those 3 classes, preferably with a single pill combination, and that was a conditional recommendation. And we made remarks similar to what you'll find in some other guidelines, and that is that it becomes particularly important to have combination therapy if you're starting at a higher level of blood pressure. If somebody is more than 20 millimeters systolic above their goal or 10 millimeters diastolic above their goal, it makes great sense to start with combination therapy. And clearly, we recommended single pill combination therapy because it improves adherence and it gives better blood pressure control. But we noted, as was noted in the ACCHA guideline, that in many countries, single pill combinations are more expensive than giving those agents as individual components. And that's a challenge. It's particularly a challenge for people who have limited income. We also noted that in those combinations, many times the drugs that are used at doses that are unsatisfactory, particularly the diuretics. So that was a concern with single pill combinations. Now, obviously, there are many trials that have looked at single pill combinations versus placebo, many of them done in India. They're very, very good. I show here just an example from what I believe is the most recent trial. This is a trial in which a single pill combination included 4 antihypertensives at quarter doses compared to a single pill step care with starting with 1 drug. And what was seen in this trial is what's seen in almost all trials. Much quicker and better blood pressure control with the single pill combination, And that pattern was seen throughout the trial and was at 12 months quite substantial in giving a better blood pressure result, almost 8 millimeters systolic better for office blood pressure. So there's no question that these agents do give better blood pressure control, there's better adherence. I won't belabor ALLHAT again, but just to say what my colleagues have said, when you're thinking about these combinations, a diuretic, to my mind, is a must, unless there's some very unusual reason for not having it in, because nothing works better than a diuretic. We showed that in ALLHAT, and I would like to think that ALLHAT is the best design trial for looking at treatment that starts with these agents. And I should just say that as we added in second step therapy and third step therapy, we were careful in ALLHAT to have similar approaches in all the arms and to avoid using ACEs, ARBs, and the diuretics and vice versa. So it's rather convincing in the way it was done and in the results. And when we look at meta-analysis of all the trials that have compared different agents, we find a pretty similar result. This is one from our colleague in Greece, Dr. Thermopoulos. And here we're looking at the effect of diuretics here, ACE inhibitors here, beta blockers, ARBs, calcium channel blockers. And we're looking at, in each instance, the agent, diuretic here, versus all the other approaches, including placebo. And here are the outcomes. And when you look at this, yellow says they're about the same. Green says that agent that we're looking at is the best. And red says not as good. And when you look at this, there's only one class of drugs where you see green and yellow and no red, and that's diuretics. So I think it's very consistent whether you look at ALLHAT per se, which I think is the best comparison, or whether you throw in a lot of other trials that are not quite as good. I want to just look at two extremes of blood pressure. And if we go to the lower levels of blood pressure, low-dose pharmacotherapy can be used for lowering blood pressure and preventing progression to hypertension. There have been 3 big trials, Trophy, Faro, and PREVER prevention. The most recent and best of these trials is the PREVER prevention trial. It's a very high quality trial. There was a multi-center trial done in Brazil. I was a part of it. And we compared low-dose chlorthalidone, 12.5 milligrams per day, versus placebo in individuals who did not yet have high blood pressure. And we showed that you could lower blood pressure, you could reduce the likelihood for progressing to hypertension. But very importantly, we also looked at left ventricular mass. And however you looked at that, when you compared the chlorthalidone group to the placebo group, left ventricular mass was reduced and left ventricular hypertension was prevented in the chlorthalidone group. And obviously left ventricular hypertension is a very important intermediate indicator of disease occurring due to high blood pressure. So that's an important finding. If we look at the other extreme, we don't normally think of using a long-acting agent like chlorthalidone in advanced kidney disease. As a nephrologist, I'd counseled against that over the years. But there's a very interesting recent clinical trial in the New England Journal of Medicine. It's a high-quality trial, randomized, double-blinded, placebo-controlled, and it was done in advanced kidney failure, stage 4 chronic kidney disease. And this was done in a group of patients whose blood pressure was not adequately controlled. And you can see here, if you compare the blood pressure experience in the group that got placebo versus the group that got chlorthalidone, there's a very big difference. At the end of the trial here, over 12 millimeters of mercury systolic difference for office blood pressure, and 10.5 millimeters of mercury for ambulatory blood pressure. Those are big differences and are very likely to result in important cardiovascular benefits in a group at very high risk. So whether you're looking at lower blood pressure or you're looking at very high pressure, the long-acting agents like chlorthalidone seem to be very important to include in combinations. And I would say going forward, we have a lot to do. We know what to do. We just need to do it. And the problem is we're not doing it as well. And whether it is in the US or it's in India or it's in Uganda or it's in China, the way to be successful is really the same. First, there has to be a commitment to be successful, whether it's at the individual level, the institutional level, the country level. Using simple evidence-based protocols. Don't complicate the process. We tend to complicate the process. Simple approaches work and work very well. For sure, health promotion, lifestyle modification is very, very important. Community-based patient-centered care, preferably team-based care, because every meta-analysis we do indicates that when it's possible to do team-based care, the results are far superior than the traditional clinician alone care. A very important one is reliable access to affordable medication. And it's a stumbling block in many countries. And there are many efforts underway now to try to deal with that. I'm involved as others on this call are in some of those initiatives. And the last, but certainly not the least, is tracking. Information systems can be simple, can be more complicated, but who's controlled in their blood pressure, who's showing up for visits, who's filling their prescriptions, taking their meds. This sort of approach, when it's applied and applied well, gets you very, very high control rates. So we know what to do and we need to do it. And I want to say thank you very, very much for inviting me to be a part of this panel.